Great. So I'm going to talk about the project that we've been doing. That overarching is to reach, engage, and retain people with opiate use disorder in effective treatment. And next slide. So this is really a quality improvement project that we're doing in collaboration with Unity and at Unity. So it's a research collaboration. It involves a number of us from Howard University, from Unity. We've got a community advisory board for the overarching project. And then we have collaborators at the University of Maryland, Yale, Boston University Medical Center, and we have funding from the National Institute on Drug Abuse Clinical Trials Network. Next slide. Just to give you the background on this, I think everybody knows that we're in the midst of continuing and actually worsening opiate overdose crisis and opiate crisis. So that graph on the right shows you the number of overdoses in the District of Columbia per year. That graph runs up to, I can't see it from there, but it runs up to 2018 when it looked like there was a dip for the first time. And unfortunately, the 2019-2020 data is worse. We're on track to exceed by far total number of overdose deaths. In the district has had the fastest rate of rise and now the highest opiate overdose death rate in the country. And it happened even though we're in the midst that we know that expanding utilization of effective treatment, medication treatment, reduces opiate deaths and other problems. And we've increased overall capacity in the district to provide medication treatment. We're not reaching most of the people who need it. And of the deaths, for instance, more than 60% happened in people who hadn't received any treatment in the last year. And overall, we think we're treating less than 20% of people who need it. Next slide. So our aims were to try to understand what's going on here. Where are there opportunities to engage more people in treatment, and to what factors account for the low utilization, and what interventions can we implement to improve it. And we're doing it in two places. In the community, and I'll predominantly, so looking at community settings as ways of doing outreach, and then looking within Unity to be thinking, what else can Unity be doing? And in both places, we're doing a formative evaluation phase, interviews and data that we're making use of to understand the current situation, and then to base interventions on that first phase of findings. Next slide. So at Unity, what we've been going through is we've been shadowing people. We've to see how the clinics work, to see where there are issues. We've been doing a series of semi-structured, open-ended interviews with individual and focus group staff members, patients, some family members, care, and we've looked at electronic health data, de-identified to look at patterns, and we've started the process of rapid coding of that interview data. And that's really what I'll talk about today, and we're leading up to this pilot intervention phase. So next slide. So based on everything, so we start back, we'll put this in terms of what are the barriers that we've identified and seen and issues, and where there are opportunities and facilitators for improving treatment. And I keep this in the context is this is a joint project because Dr. Roby and Unity leadership invited us all to be thinking, how do we help Unity do things better and better? So, when we started, Unity had relatively few providers, made great strides in that already. So back in 2017, I think you had about 16 providers of, waivered buprenorphine providers, and somewhere around 50 or 60 patients in treatment. And the issue that you had identified, Unity identified, is they're reaching a small number of people and had much greater capacity. And we also pretty quickly saw that there's, despite efforts to get screening routinely annually, that the actual hit yield of substance use screening is pretty low, much lower than anticipated. And then we look from the interviews, and what we hear is, and this cuts across patients and staff, that there's differing views of opiate addiction, what it is, differing views about treatment, misunderstandings about how medication treatment works, or what are the goals, how long should people be in treatment, or what happens if somebody's reduced but hasn't completely stopped their opiate use or using other substances. Is that a success or a failure? There's also some issues in terms of limited awareness, even about the MAT, that medication services treatment is available through Unity. So not everybody, not all the patients and not necessarily all the staff understand it or how to access it. There's some delays from the time that people are identified to getting into treatment. And then the time constraints of a usual very brief follow-up visit are make it difficult to care for the complex needs of patients with opiate use disorder, often with co-occurring medical and psychiatric problems, and then with often a host of social issues that affect both their medical and substance use disorders. Okay, next slide.
And we've got about a minute, I think.
I think we're just about done. So
Perfect.
So, so the key things are what's making things, I think real improvement is, one, there's a commitment to this type of quality improvement activity. We've done a lot of work already at Unity, independent of the project, of getting more providers, of beginning to address some of the difficulties getting immediate access to care, and to patients repeatedly talk about the quality of care when they get it. The caring staff who are flexible, and there's now this dedicated staff for rapid induction of MAT and plans for care coordination. And then last slide, I think, is what we're talking about doing, which is, so based on this, how do we go about, how does Unity go about publicizing the availability of services? What are the projects that Unity will do to address stigma and bias? How do we even further streamline treatment entry? And how do we make sure within the constraints of that brief visit that people are getting the education and counseling that they need? And that's our next phase. So the very, very last slide is just the thank you and the open for questions. And it's a reminder of this collaboration, better together, CTN, and Unity. Thank you.
So it really has been a pleasure working with you and with the team at Howard over the past year, I guess almost 2 years now, and we're really looking forward to seeing where this project goes. Do we have any questions from anyone? Lenny says she can monitor the chat, which I appreciate.
So I see one question at the bottom. Do I understand correctly that 60% of those who die from opiate overdose had no access to substance use treatment in the past year? And yeah, the latest data that I saw from Medical Examiner they presented at the Opiate Summit about a week ago was that over 60% had not received any substance use treatment in the last year. They didn't have the data of what percent had access to or were making use of primary care.
Great. And then a question also from Dr. Woznicka about the role of long-acting injectable buprenorphine for treatment, which I think is certainly worthwhile. Richard, do you want to comment on that?
Yeah. So yes, we think the idea of open access clinics and scheduled clinics is something that we've been talking about, and I'm hoping this spurs discussion. So we're still open for getting additional ideas. We'll probably continue interviewing. And I do think the long-acting injectable may make it easier for patients. There may be steadier plasma levels of it. There's a lot of worry among people about diversion issues and concerns about that may relieve some of the provider worries about it. The reality is that most of the diversion of buprenorphine seems to be getting out where people then self-start treatment in the community. And I see Eleni asked the question about low access. I can't read the end of the quote. No, it came down here. Walk-in homeless outreach vans. This is exactly this morning what Andy and I were talking about on our every other week call about where can we continue to expand that. So we're open, trying to. This is a really important problem, and we're all working at it together to figure out how are we going to get more people in, how are we going to keep them in treatment, and how are we going to get them to benefit the most from it. All hands on deck.
Absolutely. So thank you again. I think we're running short on time, so we're going to get on to the next. All right. So good.
Hello, everybody. Hi to everybody in the chat. I'm Nala, and I'm the Center and Pregnancy Coordinator here at Unity. It's a new pilot program that Unity just launched this year. It has been in the works for maybe about a year and a half under a new grant under DOH, Department of Health. So I'm just going to really just talk about really quickly about what Center and Pregnancy is and what we do. You go to the next slide, Dr. Ruby. So Center and Pregnancy is a group prenatal care bringing women due at the same time out of the exam rooms into a comfortable group setting where they can learn, share, and form new experiences and relationships and bonds. So you will see, like you see in the picture, like the group of moms and dads. And so we also welcome partners, whether that's their mom, their spouse, preferably no children, but just adult support people. You go to the next slide. Okay, so what's the benefits of Center and Pregnancy? Like, why would a mom want to do a group prenatal care rather than just her own basic one-on-one traditional care? So basically, the benefits is that they have better health outcomes for the mom and baby. Self-care, so the patients learn how to advocate for themselves. So in sessions, they take their own weight, they take their own blood pressure. Of course, it's monitored by another clinician, but this gives them the opportunity to take role of their own health. Support and friendship. This allows moms that's doing the same to create a community that they might not have had outside of their home. Self-confidence. This builds the skills of the moms to be and their partners into the role of parenthood and just navigate in pregnancy and labor and delivery. Learning and fun. Of course, Center and Pregnancy is a very, very interactive. We have a lot of different activities that we do. It's super fun. We laugh a lot. We have a lot of fun in centering and more time with the provider. And this goes both ways. I see it as a win-win. So the patient has more time with the provider, meaning instead of having those quick 15-minute intervals of a prenatal visit, patients actually have up to 2 hours with the provider. So all the questions that they want to ask, all the things that they want to get out, provider to talk about those different things. And so this also allows them, the patients, to learn the provider who they are as a person rather than just as a doctor or nurse midwife, and vice versa. The nurse midwife or the family medicine doctor gets to learn the patient as who they are as a person rather than just a patient. And so, okay, you go next slide. Okay, so how do we do centering? And it's three main components of how we do it. One is the health assessment. The second is community. And the third is interactive learning. And then you go to next. And I also want you all to notice, as I go through the slides, you can see a lot of color, a lot of imagery, like for this slide, for example, because we really focus in on patients, no matter their background or ethnicity or anything like that. We also focus in on like having a lot of pictures for patients that might not have that might not be able to read a lot or well. And so in this picture, this is kind of, I know it's like a little jumbled up. I tried my best to like, I don't know, make it look nice. So this is kind of how we would have our groups, right? So we have a circle, as you can see, the chairs in the middle. Then you have a clock on the wall, and you have to have windows because you gotta have that natural sunlight come in, right? You gotta have that good energy coming in. And then we have something called a parking lot. It's the whiteboard to the right top of the screen. And patients, while they are talking and eating their snacks and drinking water and conversing with one another, they can write their questions that they have so it can be addressed in the session. Questions that you might forget while you're doing your one-on-one prenatal visit, like, oh, I meant to ask the doctor that. They have more than enough time to write those questions down. And then we have like a set room for patients, their center in session. And in that room, we have the circle of chairs. We have snacks, as you can see to the top of the screen, with water. They have their name tags so everybody can identify everybody. Then in one section of the room, they have where they take their own blood pressure cuffs, their own blood pressure, and their own weight. And as they do that, they take their turns doing that. And as they do that, some people might be eating snacks and drinking water. Someone else might be to the other side of the room getting their babies checked. So like the regular thing you would do in your traditional prenatal care, as far as like heart rate for the baby, the provider asking any personal questions that they need to ask the patient. So that's kind of closed off in the room. It's still in the room so the patient can feel as part of the session before we actually start our conversations. But that's why I have like little plants and things like that. So one thing that we will create in our rooms, before COVID had hit, but one thing, the goal to create in the rooms is privacy. And so plants and maybe just some type of barrier so the patient can feel that she has her privacy in that moment when she has her one-on-one. And then once she's done doing her check with the provider, she can go back into the group and, eat some more snacks and converse with other moms. And then they also have something called a centering notebook. And what that is, and they have pens, of course, they can write their notes and it's theirs. And they can write notes, it's theirs. And the best part about it, they can take all the notes they want in it and it's theirs to keep. You can go to the next slide. I think that was everything.
Okay, we've got about a minute left.
All right. So we'll just zoom through this. I'm not going to read it. So the health assessment, this is where the patient takes ownership of their own health, right? So they take record of their own pregnancy record, of their own health record. And we also ask them in their center in pregnancy, how do you feel? Your physical health, your mental health, and managing your stress. So they take they write their own date, they write their own how many weeks they are, blood pressure, weight, everything. They write everything in their own notebooks. Of course, the provider writes these things in ECW, of course, documented. But this is giving the patient the ownership of their own health. You go to the next slide. Okay, so just some of the learning activities that we do is we always open up with openings. Sometimes we do mindfulness activities. Sometimes we do a little bit of yoga, a lot of different things. And we always do activities, fun activities. And then we always close with a closing. It's been interesting because we've been doing it through Zoom, but it's fun. We still have fun. We go to the next slide. So I can. And then the last is community building with group and guidelines. So this is the guidelines we post in our rooms for our moms and their partners and whoever they choose to bring. So the group always starts and ends on time. We respect and value each other. What is said in the group stays in the group. And everyone is safe, welcomed, and included. And we definitely live up to these standards. Some people might think, well, what if I say something that has to do with something that's very personal to me? And that's why we say what stays in the group, said in the group, stays in the group. And we also have patients sign a confidentiality form. So that is a documentation that we have in our ECW that we patients sign to say, you sign and acknowledge this. You can go to the next slide. Okay, go back one. Sorry. So one of the interactive learning examples that we have, so the opening is 3 words. So So for example, I would say, so give me 3 words to describe you, or give me 3 words about how you feel today, right? And then an activity we would do is something called Glorious Food. And this is really interesting that we do. We pull up a screen that has all these different foods, good foods, bad foods. And so the patients decide which foods is good and not. And then we talk about it. Why is it good and why isn't it? And then the closing, one example I had is called Centering 3 Breaths, and where we just kind of just bring ourselves back into the moment and just let good energy flow. The next slide.
Great. I think we've got about 15 seconds to wrap up here.
So some people say, why not
Right.
why a group and not just a class? Why? Because a class is someone teaching you. We don't want to teach, but we want to give patients good information, but we want them to learn that information on their own. So we do process content, open-ended questions, engaging the head and the heart in the healthcare, right? So we engage patients with open-ended questions. We engage them. So when we engage the head, we do data, but we don't overuse data, right? We don't overuse information. We keep it very simple to the patient, and we deliver the information on a consistent and frequent basis. And engaging the heart, we just create surprising and compelling visual experiences. That's why we have a lot of pictures and colors. Use storytelling and understand and respond to what people are feeling. And we have to bring energy and enthusiasm as we go along. I think it's just in us. We could yeah. I think because it was just one more slide. Yep.
Okay.
And that's just that's fine. Any questions?
Wonderful. Great. Yeah, thank you so much. That was a great presentation. We're super excited about the centering program. Centering was one of the first programs, I think, to group visits to go virtual when the pandemic hit. So that they were really led the way there. I think we're a little short on time. I see let's see, a couple questions here. Who else do the patients get to hear from during the sessions besides the provider or their educators or other group leaders?
So yeah, every session, by the model of centering, you have to have a facilitator and a co-facilitator. So the facilitator, of course, is the provider, the nurse midwife, the family med doctor, and the co-facilitator is like, it could be a medical assistant or just somebody that's in the clinic that can support the conversation, because you have to have a clinical and non-clinical aspect of these conversations. And then
Great. And then I saw some questions about if it's for what sorts of pregnancies, and so generally low risk pregnancies, right, and can replace really all the prenatal visits that patient has during the course of their uncomplicated pregnancy.
Was that goal of moving low risk patients into centering. So right now we only are seeing low risk patients. We will have like high risk groups, but that's later on down the line.
Wonderful. And I see some of the questions being answered in the chat here. So in the interest of time, we'll move on to the next session. I think Dr. O'Donovan is with us. So Eleni, if you want to try to share your screen. Thank you very much, Nyla, for presenting.
Thank you.
Okay.
So I'm going to try and talk for 5 or 6 minutes about our, what I think we very much viewed as a fight against COVID-19 at the DC jail. I do want to say, and I kind of talk about this towards the end of the presentation, that while I'm sort of representing DOC today and doing a little bit of an overview, this was absolutely an all hands on deck effort. And it is not representative of me, it is representative of the whole team at the DOC coming together and doing a phenomenal job. Next slide. So, you know, we, like everybody else, I think, in the country, started really understanding that COVID-19 was going to be an issue, you know, that kind of hearing a little bit in the news in January. And then I think by mid-February, maybe end of February, understood that this was going to have a significant impact in the United States. And we actually started meeting and talking about it with leadership towards the end of February. It was very hard to understand how significant and really prepare. But we were aware that if we were hit hard, it was likely to have a significant impact in jails and prisons. And we immediately started talking about infection control efforts, both kind of with the clinical unity team, but also with custody. So working at DOC is very much a partnership. We are contractors there, contractors with the Department of Correction, and everything we do is really in partnership with them. So fairly quickly after we knew that COVID-19 was in the United States, in mid-March, we implemented some of the things that we also did in the clinics outside in the community and really across the country. We started doing temperature and symptom screening at all of the entrances into the facility. The DOC started a kind of systematically cleaning the cell blocks where residents live and the rest of the facility every 2 hours with disinfectant. We wore masks ourselves, but also gave masks to our residents so that there was universal masking throughout the facility. Social distancing went into effect, and like many federal buildings and city buildings, we have signs, like pretty much every inch of the walls at the DOC are covered with signs about hand washing and social distancing. And then probably most importantly for a facility like ours, we started working with custody to think about how we could get residents into their own cells and not be housed with other individuals. Despite all of that, and not surprisingly, we did have our first case at the end of March, and likely representing an infection brought in by a sick correctional officer, which is really the case throughout the country. And this was the time that places like Cook County and Rikers in New York City started having their outbreaks as well. And I think those were really well publicized. Next slide. So we've been working, I want to be clear, this beautiful slide is really not mine. We've been working on a few projects with a research team from Emory University and Albert Einstein. We're looking at various things, aspects of clinical care. Kind of a side project became COVID, and they helped us put this together. But this really shows kind of the curve of our pandemic within the facility, starting at the end of March, and this goes through the middle of June. And what it shows is, really what we saw throughout the country. I wanted to highlight that the numbers in red represent the numbers of ill patients we had at any given time in the facility. So at the height of our outbreak, we had 55 individuals in isolation that were being taken care of by the provider group that was rounding on COVID positive patients. And around that time, we had over 1,000 residents in quarantine because they were exposed to sick inmates. And quarantine at the Department of Corrections means that we come twice a day and we check your temperature and your symptoms. So I'll talk a little bit about this in a slide or two, but it represents an enormous amount of work, particularly on the part of our amazing nursing staff. To date, we've had, I think it's 217 cases with 2 that we're sure were COVID, but never got tested or had a negative test, but we're still sure it was COVID. But through the middle of June, that was 207 cases. So obviously the bulk of the cases were during this time. And at the end of the day, almost 9% of the population fell ill among our resident population. In contrast, of the folks that were tested in the community in DC, about almost 13% tested positive. So that, in other jurisdictions, I think jails and prisons had more cases on the inside than they did in the community. But while we did experience an outbreak, we're better than our population that was on the outside. Probably one of the things that we're proudest about is we only had 1 death. So our resident population is fairly sick. For our COVID patients, over 40% of them had a comorbidity, an illness like diabetes, hypertension, asthma, or morbid obesity, heart disease, COPD, stuff like that. And out of this whole group of sick individuals, only one died. And that statistic is really amazing. And next slide, please. That I attribute to kind of the level of care that everybody provided our residents during this time. This is just a slide showing single selling, and kind of one of the reasons why earlier on in the outbreak, it was probably harder to control, but as we worked together as a team and were able to rehouse residents in different areas of the facility or spread them out more, that slowed down the infection rate. So at this point, also because they let a lot of people out of jails and prisons, they decarcerated people during this time, we're able to put almost everybody in a single cell, which obviously helps a lot. Next slide. Okay.
We've got about a minute or two.
So I'm not going to read this all the way through since we're short on time, but I just wanted to highlight that we really upped our level of service across all of our departments. This probably doesn't mention everyone, but it highlights some of them. Again, nursing did just an extraordinary level of work, and we did over 30,000 temperature and symptom checks on folks during this period. And we continue to do them whenever we're worried about a group. Our sick call team started seeing people within 24 hours. Mental health stepped up. I don't know that our infection control nurse extraordinaire, Keisha Robinson, slept during these few months. It just really amazing amount of work, just changing all the aspects of the way we deliver care to keep people safe. Next slide. So I'll stop there and take any questions. Again, I really just want to highlight the incredible work that the entire team at the DOC did during this time, from the folks who, carry supplies from one building to another, to, quality improvement, nursing, pharmacy, everybody, mental health, really amazing team. And we couldn't have done it without our teamwork. Thank you.
But anyway, do we have some questions in the chat? I unmuted you. It says, was the DOC open to your recommendation?
Yeah, that's a good question. They were. I mean, it's always sometimes a little bit of a push and pull because you're balancing safety and custody concerns with medical. But I think in general, we worked really well together and, kind of stepped up our meetings. And they really did a great job with just the stuff that really counted, like giving masks out to folks and basic sanitation. All right.
Great. Do you have any idea how many inmates ended up in the hospital from DOC?
To put in there. Yeah, it was about 10%.
Okay. And they then returned to the DOC usually after hospital discharge? Yeah. Great. Wonderful. Thank you so much. It really was remarkable work done at the DOC by the whole team there.
So good afternoon, everyone. Thanks so much for having us. Our study is titled Improving Access to Colorectal Cancer Screening Through Mail-in Fit Testing. Take it away, Sam. Next slide.
The stats show colorectal cancer is the third leading cause of cancer-related death in the U.S. And incident and mortality rates are highest in African Americans and those with low income. Early detection and treatment proven to be saving lives. Next slide. This statistics shows our population screening rate for, I think this data was taken in 2018, and about 34,000 Unity patients need to be screened for colorectal cancer. Next slide. This can be done through two tests. It could be fit testing or colonoscopy for some patients. Next slide. Our aim for this study is for Cardozo Clinic set out to increase the number of patients who are indicated to receive annual colon cancer screening to receive it annually. Next slide. Our methodology, initially all patients who meet the criteria for colon cancer screening were issued a fit test kit and instructed to return the specimen to the clinic within 30-day period of time. The patient would return the specimen to the clinic. In this process, they will go to the bronze team for registration, and then they will go to the lab to drop off the specimen after signing in, which takes longer process. In the effort to make this process leaner for the patient as well as to increase compliance, the new process put in place allowed the patient to mail in specimen once they collected it at home. The patient was given the option to mail in or return to the clinic just to drop off without lab registration. And with this new mail-in process, we collaborated with the clinical staff as well as LabCorp, and it includes training and education about patients, how to educate patients, how to order how to put the order in our EMR system, and the lab processing. Next slide. There are a few important steps that, in order to accomplish this new method, there are a few important steps that we need to perform. Basically, the first step will be identifying the patients who need fit testing. Zara will tell us if the patient is due for fit testing, ordering the fit test, instructing the patient, and the last step will be drop off or return the specimen back to the clinic or drop off at the LabCorp. Next step. Next slide. Ordering fit test. The change with the new process is we added a template. We created a template in ECW so that a provider or the MA could be able to order the test without going the old process. And if we go to the next slide, we can be able to see how it looks like in ECW. Next slide. Again, these are some of the steps we will need to follow, and the next slide will show us. This will show us after we use the template. It includes the diagnosis code, and we will see under the assessment the patient is doing the screening for colon cancer. Next slide. Second step is processing the order in ECW, which is completed by the MA. This is basically documenting, and there are some specific changes that we train the MAs to do, and there are some notes that we need to put in under the note section. Next slide. Printing a requisition. This order, the difference between the current method and the previous method is this order needs to be a current order, not a future order. And once the order is put in place, we will have to deselect every other order if there is any, and only process the fit. And it looks like this in ECW. After this, the fourth step will be printing out, which is on the next slide. We will print out 2 requisition forms. One will be given to the patient along with the fit kit, and the other one will go to the lab MA. Next slide. We also print a label that goes again along with the kit. In that label, we would have to put the date and time and leave space for the patient to put on the date and time of collection of the specimen. Next slide. And then the final steps are we will instruct the patient to perform the test, and then instruct them how to return the specimen back to the post office, or again, the second option is to drop off at the site without lab registration. So through this new process, we were able to see the results on the next slide.
So with our results, again, our pilot study was done in August and through September 2019. And in that study, we were able to see a significant increase in the number of fit tests that were done. In August, we saw a number of 204, but by September's end, Upper Cardozo had 800 completed fit testing done. Next slide, please. Our pilot showed positive outcomes. However, due to the pandemic, the implementation process throughout our sites had been placed on hold. As a result, we recommend to apply this process unity-wide to improve our colon cancer screening. The pandemic also led to a decrease in the number of our inpatient visits. Therefore, patients, we also recommend that patients who are eligible for fit testing, that we work on trying to mail out fit testing to their homes and follow up with them via phone call or the portal, etc. So that's something that we would like to take on as a result of this. So thank you very much. And if you have any questions, please feel free. We'll check in the chat.
Oh, I was on mute, I'm sorry. So I was just saying what a great presentation and really a remarkable increase in the number of fit tests returned. Have you been able to continue doing this at all during the pandemic?
It has been on hold, but our hope is to reinforce with the staff and, you know, pick it back.
Great. Yeah, I think this is something that could be done at really all of our clinics.
And so we're also actively trying to look into mailing out the kit to the patients. I think that would help during this pandemic. Mm-hmm.
Absolutely. Very good. I see Dr. Herman just saying how much her patients appreciated being able to mail the kit. I see a question about Cologuard coverage. I'm not sure anybody has any information on that, which is another screening option that requires less frequency. Kathy asks, would you confirm the address before mailing the kit out? If we're going to do the mail out option, I think the answer to that probably is yes.
Jinx.
Our patients often are mobile and you know, move from place to place frequently, some of them. Okay, well that's about all the questions I see. Thank you again for the presentation. Thank you to all the presenters. Those all were really excellent.